uh, to the next talk. Dr. Samendra Karkhur is an associate professor at AIMS Bhopal, and he's going to simplify tubercular uveitis for all of us.
Thank you, Dr. Samyak, Dr. Mayur Morekar, and Ajanta Pharma for this opportunity. It's not as simple to simplify tubercular uveitis. I think it's the hardest job, so I'll try. So why do you need to simplify? Because irrespective of our specialty, training, or interest, we must treat and understand uveitis because we are all treating inflammation of some kind at some point in a clinical practice. Another very important reason is simply that in India, the numbers tell us to do that. So India carries one of the largest global burden of tuberculosis, which is about 1 in every 4 patient, of which 85% is pulmonary, about 15 to 20% is extrapulmonary, and of that extrapulmonary, about less than 1 to 2% is ocular tuberculosis, which is underestimated, underreported, and underdiagnosed. So if you see the organ involvement, the eye features the lowest in the chart among other organs. Ocular TB can virtually involve every tissue in the eye. The Mycobacterium tuberculosis loves the oxygen and the high blood flow. So obviously the area is uvea, and of uvea, the choroid is what is most liked by MTB. So a patient walks in your clinic, how do you diagnose? So the most important thing, and which you will hear time and again in this session, is the morphology. You need to identify the morphology and does it fit the clinical picture of tubercular uveitis, and everything else follows. It's like somebody has a fever. Fever can be due to 100 things. So you need to identify the pattern of fever and see where that pattern fits, and then you take your investigations forward. Sun classification has been very, very helpful for all uveitis specialists, and I think it's not just for uveitis specialists. Everybody should have an idea of sun classification to grade cells in flare. Now, clinical picture of tubercular uveitis, I would detail a little more about the anterior uveitis because that's what the journal ophthalmologists are going to see most often. So whether granulomatous or non-granulomatous, both can lead to tubercular uveitis. The mutton fat KPs are large KPs, granulomatous ones. The iris nodules, capes at the margin, basaka in the stroma, and the Bellin nodules in the antechamber angle. So, but you should remember that granulomatous KPs can be due to several reasons: toxo, herpes, sarcoid, endophthalmitis. None of them are TB. This is a case of sarcoid with large granulomatous KPs. This is a PCR proven herpetic uveitis case where you see the heavily pigmented central distribution KPs, and there are no K here. But so this is how you know this is not tubercular. Again, this is a case of Fuchs heterochromic uveitis where you see central distribution, whitish KPs, and there are no K again. But all of these cases will be associated with high IOP. So uveitis entities associated with granulomatous KPs. This is very important because you will first see granulomatous KPs and think of tubercular uveitis. So you need to know that there are so many non-infectious and infectious causes which can cause granulomatous KPs. You can actually get some idea based on the distribution, type, color of KPs that which direction is is this uveitic entity directed into. So I'll not go into the details, but yes, we can get a lot of information from that. Next is your intermediate uvea, which basically is identified with cases who have snowballs or snow banking. You need an indirect ophthalmoscopy, very important, with indentation to know exactly what is the extent of disease. And posterior segment, you can have, most importantly, tubercular uveitis presents with either choriocapillariopathies, choroiditis, or vasculitis. If there is a pure retinitis, remember that it may not be tubercular. You need to consider and rethink your diagnosis. Ocular TB can be of two types: direct infection, immune mediated. Immune mediated, you all know that you might have come across flicular conjunctivitis. That is a hypersensitivity reaction. There is no MTB there. And you know, if you don't treat with ATT, it's not going to go away. But there can be a direct infection. In almost all cases, it is paucibacillary, unless and until you misdiagnose, wrongly treat it, and push it into multibacillary. Again, another important thing is tuberculosarcoid versus sarcoidosis spectrum. So tubercular uveitis is purely infectious. Tuberculosarcoid and sarcoidosis is autoimmune. So this differentiation is very, very important to make when you come across a case which you are suspecting to be of TBU. How do you investigate? So investigation is basically a conglomeration of your history, your immunological testing, radiology, imaging, and other microbiological examinations. COTS tuberculosis guidelines have made things very, very simple for us. It is as much helpful for general ophthalmologists as it is for uveitis specialists. It combines immunological evidence, radiological evidence, history, microbiological evidence, of course, with killer phenotype suggestive TB at its core to help you make the diagnosis and help you arrive at a decision whether to start ATT or not. It's a freely available calculator available online. You can quickly use it in your clinical practice and it will help you make a decision whether, because committing a patient to ATT is not a small thing. It's almost for a year somebody has to take these toxic drugs. So you need to be very sure, and the patient also has to be very sure. So this is how we diagnostically categorize tuberculosis, where you see that it could be confirmed, probable, or possible. You see at the core of all this is clinical phenotype, which is always required, and that's where all the spokes of your wheel start. After that, you combine it with COTS recommendation, and you decide whether to give ATT or not. Government guidelines are pretty clear. It's under extrapulmonary TB, and the tests and treatment are all free. The only thing to remember is that during the intensive phase, you give 4 drugs, but during the continuation phase, we don't give 3 drugs. We give only 2 drugs because ethambutol has a proven toxicity. And sometimes with uveitis, it gets mixed and masked, and you don't know what the vision drop is due to. Again, treatment of tubercular uveitis has essential role of corticosteroids and along with ATT, because you need to take care of the inflammatory arm of the uveitis along with the infection. Immunosuppression is best left to physician or a uveitis specialist who are more trained in to handle, because the moment you feel the immunosuppression is required, I think it's the best time to refer that case. So when do you refer the case? Of course, you're not going to be treating all kinds of uveitis, because even uveitis specialists sometimes fumble with a lot of cases. So if there is a diagnostic ambiguity, if an invasive test is required, you don't have the armamentarium, there are sight-threatening complications. It is important to recognize them early and refer the patient. One such example is disseminated or miliary tuberculosis. And there are certain special case scenarios like children, immunocompromised patients, HIV co-infection, because it can present with a similar picture with multiple etiologies in like mixed infection. So these are the cases which you need to be wary of and not drag them unnecessarily in your clinic, and it's better to refer them early. And just go through quickly one case. This is a simple case of posterior tubercular granuloma. This patient was treated with simple PST Kennicott outside without any workup. She came to us because she had an IOP. You can see the result with MON2 positivity, TB contact positive. Patient was treated with ATT and did very, very well. But sometimes things can go very wrong. This case we came across at PGI Chandigarh. It is Mohit is right here as one of the co-authors. This was a case of simple tubercular granuloma, advanced to subretinal abscess, because the physician, the ophthalmologist kept giving oral steroids without any workup for TB. The disease went into, this is the right eye, which was normal. The disease went into overdrive. The ophthalmologist didn't stop there, gave an Ozurdex on top of all this. And you see, when the workup was done, it was positive from every aspect for tuberculosis. This is what happened to the patient as tubercular endophthalmitis. The whole idea of showing this case is that TB can have, this is a multibacillary disease where it progresses to tubercular endophthalmitis. The eye was eventually lost, and even the culture grew TB bug, Auromin, Rhodomine, Zeal, Nielsen, everything was positive in this case. Thank you very much.
Thank you, Dr. Samendra. Yes, you're right. It's not easy to simplify tuberculosis. Uh, you told us again about an overview, one anterior segment sign that is granulomatous anterior uveitis. So granulomatous disease. Posteriorly, if you see choroiditis, vasculitis, with or without choroiditis, and serpiginous like choroiditis. I think these are the 3 to 4 most important clinical signs if you want us to recapitulate, which should lead to a suspicion of tuberculosis. I would like to ask one question to our chairperson, Dr. Somshila Madam. So my question would be, I mean, I think would reflect everyone in the audience. And is TB in the eye an infection or an inflammation? I
So I know you're asking a loaded question, and you obviously know the answer. So the current concept is, of course, it's a hypersensitivity reaction or process actually. So in that way, there is the immune system which is activated and participating in what we see in the eye. But at the micro level, perhaps in the RPE cells, there are enough publications, and Dr. Basu and Anup, they have all worked on those data, which shows that there can also be bacilli in the RPE cells, so in the uvea, and therefore it's definitely a mixed mechanism. So that's why we definitely need anti-tubercular therapy, as well as later we need whether it's steroids or sometimes even immunomodulators. I think Anup, if you have a quick comment.
So I think just to add what you said, Professor Dr. Amod Gupta sir's paper, he also denotes that the RP cells can carry the MTB for years together. At times, I think that there was a mention of up to 15 years. So, and the immune reaction, of course, the immune self cells outnumber the number of MTB, but I think it makes sense to treat for both.
Right. So essentially, most of the TB that we see in our clinics is possibacillary, if I'm not mistaken, and it does require to be treatment with steroids and AKT if the tests are positive. What tests is the immunological test, the Montu test, or the IGRA test where required, and radiological testing. So if either of these tests are positive, and I think you've given a beautiful description of the COTS calculator as well as the standard TB guidelines by the government of India. One question to Mohit is from PGI where a lot of TB work is done. Mohit, if is there a case, a scenario where the tests are negative, but you would still want to give AKT?
So, loaded question. Medical legally, you're putting yourself and everybody at risk. When we say tests are negative, I'm going to look at this from a lens of three things. You have your two immunological tests, you have your MONTU, you have your quantiferon TB or IGRA, whatever you want to do. And I think if you want to label radiology as negative, I think it's important to get a CT chest. Between all of these, I think if you are getting a chest X-ray negative, then it is not actually, it might not actually be negative. You can get your serological test to be negative if the bugs all over the body. He showed a case of miliary TB. If the body is just not able to mount an immune response, there will be no immunological test which will actually be there. But the phenotype then has to match. So if the phenotype is that of a multibacillary TB, which is not what we commonly see, if you typically have a choroidal abscess or choroidal granuloma, or you have what looks like an infectious scleritis with those multifocal pockets, um, um, a negative or a zero Montu with absolutely, the IGRA not coming up, I think a search elsewhere is warranted because then you would have the bug at least somewhere else. If the CT is also negative, just to empirically start ATT would be a bit of an overkill. Having said that, it doesn't rule out TB if the phenotype is multibacillary. If it's intermediate uveitis or if it's a granulomatous anterior uveitis, and all of these are negative, and we are still, because we think the pre-test probability in our mind for TB is high, and we still want to keep harping on TB would be wrong. But if the phenotype is multibacillary, and our test TB should be kept in mind, and we should ensure the CT chest has been done, and also look at other sites. You can have abdominal, CNS, it could be all over the body and just not in the chest. So just starting at the get-go, multibacillary phenotype, higher index of suspicion, more imaging, possibacillary phenotype, CT chest normal, immunology negative, I would say don't.
Excellent point. I think point well taken. And I think Dr. Mayur would want.
And when one is talking of CT chest, one has the option of doing a plain CT chest or a contrast CT chest. If the phenotype is too much of TB, then it may be better to just straight away do a contrast CT chest. And again, if the phenotype is too much and the contrast CT chest is reported as normal, it may be a good idea having that read by somebody else, some other radiologist or a pulmonologist who may still pick up some signs of old TB.
And just want to add one more point that when we look at a CT chest, it's not what the pulmonologists are looking for when they want to look at pulmonary TB. There will hardly ever be, in less than 10%, in fact, that might, in less than 10% patients with ocular disease because of TB, will there be active TB in the lungs. So if you get it, if your radiologist or your physician or is not seen or is not well versed with ocular TB, or extrapulmonary TB, they will look at or they might report and also the radiologist will report, some sequelae of past infection, some lymph nodes. Now that is important for us because it'll be very rare, if ever, to have active disease in the lung and active disease in the eye. We are not looking for active disease in the lung. We are looking for evidence of TB exposure with the Ghon's focus or with lymphadenopathy prior, which is adding to our immunological test that we have done now, along with the phenotype that we clinically saw on the slit lamp. And all of those three things come together. So a radiology that says there is no cavitation, there is no tree in bud appearance, none on CECT chest, there is no activity of lymph nodes, does not mean that the CT chest is negative from our viewpoint.
I'll just add one line to this.
Sure.
Like lot of us refer our patients suspecting tubercular uveitis to pulmonologist to start ATT. And the pulmonologist or a physician looks at CT or whatever chest X-ray and says there's no evidence of TB, there's no need of ATT. So that's the point that you need to remember.
So I think it makes sense to open lines of communication with your radiologist and your pulmonologist to tell, look, this is a phenotype of tuberculosis that I'm seeing. Look for healed, old, anything that suggests tuberculosis.
Also, simply what one can do is read the entire report, not read the final impression, because the final impression is written from the point of view of the pulmonologist. It will just say abnormality detected. But when you start reading the report, you will see a lot of things there in the report, which would be like, in sync with ocular TB.